This is Emily Peters recording for Advanced OB Peds, renal, endocrine, and gastrointestinal disorders. So one of the biggest renal disorders related to cancer is the Wilms tumor, also known as nephroblastoma. This is the most common malignant renal and intra-abdominal tumor of childhood. It does occur on the kidneys. It has a 3 times greater chance of occurring in the African American population. The incidence is higher in boys versus girls. However, if caught early enough, the survival rate is in the 90th percentile. As you can see from our slide, most of these kids are diagnosed when they're fairly young. And about 1 to 2% of the cases have an origin related to family. However, the last I heard, there is no way to identify carriers for this type of cancer. So diagnosis, we got to do that good history and physical exam. So that presence of congenital anomalies is not uncommon. Family history of cancer. Signs of malignancy. So remember back to our leukemia lecture and the signs and symptoms of a child that is having some sickness like weight loss, size of the liver and spleen are swollen, anemia, pallor, infections, nausea, vomiting, things like that, high fevers. A lot of the times when we're doing our history and physical, we're going to find out that the reason those patients were brought to the doctor was because they've noticed that abdominal swelling that won't go away or an abdominal mass is noted. We're going to do abdominal ultrasounds to see where it's at, what we're dealing with, and that's where we'll see the cancer on the kidneys, kidney or kidneys, and kind of see how much is involved, possibly. We'll also do those chest CTs, a urinalysis, because that's going to give us an idea of the kidney functioning. Hematologic studies and kidney function studies. Once again, we need to know the functioning of the patient's urinary system and kidney systems and how everything's working. Most cases of these kids, the cancer usually only occurs on one kidney. However, about 10% of cases, both kidneys are involved. Okay. So some things they can do for treatment would be chemo, radiation, partial nephrectomy, cryoablation of freezing of cells, different things like that. And I'll get into that more in a couple slides. Okay, so some other signs and symptoms we may see when this child is brought into the doctors, or we want to make sure we ask about the presence of blood in the urine. So is it pink, red, Coca-Cola colored? Those Coca. What am I seeing? What are the parents seeing? Is there back pain just below the ribs that doesn't go away? Typically it's going to be that back side, but some might have it off to the back of their, not quite flank pain, but along in those lines. And maybe off to the side a little bit of their, where those kidneys are located. Weight loss, fatigue, fevers. Okay. So all kids are going to end up with surgery and chemotherapy, radiation therapy at some point. If only one kidney is involved, they're going to do chemotherapy last. So what they're actually going to do if one kidney is involved is they're going to go in and remove as much of the tumor as they can, and more than likely they'll have to remove one kidney and possibly the adrenal glands. And then, of course, they're going to biopsy those lymph nodes that are around that area. And then they will do chemotherapy and radiation afterwards because of the possibility of the metastasis that occurred. Now, if both kidneys are involved, they're going to do the chemotherapy and radiation first to shrink as much of the tumor as possible so that they can save one of the kidneys. And then they will do the surgery, and then if needed, they will continue with chemotherapy and radiation afterwards. So, nursing care. What do I need to do when we are diagnosing this child? Well, we want to get that swift diagnosis. And then a lot of the times they're going to go in for surgery within 24 to 48 hours. Or we're going to start that chemotherapy and radiation if both kidneys are involved. If the doctor has not ordered a sign, guess what sign I'm going to be putting up on the room? On the wall of the room so everybody knows. Do not palpate the tumor. Do not touch the abdomen. Do not mess around with putting a lot of pressure on there. Because what's that going to do? Manipulation of the abdomen could cause an increased risk of the metastasis. So putting those signs up is going to help notify everybody and anybody that goes in the room to be careful. So if I've had an intra-abdominal surgery, what do I have to look for? Well, intestinal obstruction could be one thing. Could we be at high risk for an ileus? So what are those signs of an ileus? You guys should know this from earlier in your nursing studies. Radiation can induce edema. Post-surgical adhesions can afford a formation. So just like with anybody else that's had an abdominal surgery, we need to be doing those good assessments. Looking at bowel movements, listening for abdominal sounds, the bowel sounds, measuring for distension, observing vomiting, pain, and everything related to the movement of the bowels. Okay. There's several gastrointestinal system anomalies that we're also going to talk about. Esophageal atresia and tracheoesophageal fistula, omphalocele and gastroschisis, gastrointestinal obstruction, you guys hopefully have covered before. So obstruction of the GI system, what do we do? Meconium ileus, things like that. Imperforated anus means that we have failure of the anorectal development in the 7th to 8th week of gestation, and there's no anal opening, and and there's a fistula from the rectum to the peritoneum or the GU tract. We'll have to do a central surgical intervention. So to give you an example, one of the babies I took care of, she didn't have an anus, but the stool was actually coming out of her vagina. So those are some things to be aware of when you're doing your assessments. Okay, so omphalocele and gastroschisis. These are similar disorders. The omphalocele is this one right here. The omphalocele is a umbilical ring defect, so it's going to occur at that umbilical cord site. And so you have an evisceration of abdominal contents into the external peritoneal sac. So you have the sac following the abdominal contents, and all of that is popped out and on top of the abdomen. Gastroschisis, which is right here, it is off to the side or below the umbilicus. The umbilical cord is not usually involved. This is a herniation of all those abdominal contents through the abdominal wall defect. And there is no peritoneal sac to protect that that tissue. So what do we do for patients with these issues? We need to get them ready for preoperative care. Just think about this. We have extra body surface area. So if that baby has extra body surface area, what's that going to put them at high risk for? Hypothermia. It also is going to put them at perfusion issues because this stuff is being expelled through a tiny hole. We also are going to be at high risk for fluid loss. And then the contents that are exposed are going to be at high risk for trauma or infection. Okay, this patient could also have intestinal distension and, like I said, fluid volume loss. So we got to maintain those fluids and electrolytes. So our main goals when taking care of these patients is preventing that hypothermia, maintaining perfusion of those abdominal contents, minimizing fluid loss, and protecting the contents from trauma. So how do I do that? So the big thing we can do to help with several of these is to put something over top of the contents. So right after birth, if you don't have the right stuff at the delivery room, they will take a bag, a plastic bag, and put the baby's legs through it and pull it up to their armpits and seal that off until the surgeons can come in and look at it. Otherwise, what we can do is put some sort of a Vaseline gauze over the site and then like a tegaderm or something sealed around it. Now, typically, the gastroschisis is going to get put into a silo or a huge bowel bag eventually, and I'll show you a picture of that. Okay. Also, by covering the site, what does that do? That helps with protection from trauma. It helps maintain perfusion a little bit. It's going to help minimize fluid loss because the area is going to be covered up. And it's also going to help with that temperature regulation because not as much body system is completely exposed to the air. We're also going to make sure this child is put on antibiotics. We're going to start fluids for that electrolyte replacement. We're going to do gastric decompression and get that bowel ready for surgery. Okay? And then they're going to need good thermoregulation, so they're going to be on like a warmer bed. They're going to get surgery soon after birth, and they're not going to get fed for several weeks. So we're going to have to start total parental nutrition, TPN, NVN, CVN. Okay, omphalocele survival is pretty good, and so is gastroschisis. So this is another picture of the omphalocele. So you can see it's a covered defect. Not very much is exposed on this one. I've seen bigger than this. These kids can also have not only omphalocele, but the gastroschisis can have defects that involve the GI system, the musculoskeletal system, the GU system, and nervous system. Okay, with these small defects like this one, that saline gauze and like a plastic wrap, and then doing like a big old tegaderm to stick over it would probably be very effective. Okay, so here is gastroschisis, and this is a fairly severe one, and as you can see, it's off just to the side of where that umbilical cord is. So you can see there's a lot of that bowel that's herniated. If you think about it, if we know this is going to occur, guess what? This baby's going to be born by C-section because we don't want to cause damage to the gastroschisis. The same for an omphalocele as well. Okay, so they're going to be born by C-section, omphalocele and gastroschisis. With the gastroschisis, if you think about that, abdominal contents is not protected at all. And it's being exposed to all that amniotic fluid in the movement of the baby. So you could have some necrosis. That bowel is going to be very thickened and edematous and inflamed due to that exposure. So with gastroschisis, there could be a higher chance of needing to remove part of the bowels during the surgery. Okay. So this is a silo that is used for the gastroschisis before surgery. So the silo is what it's doing is we put all that contents up into that sac, and it allows gravity to push all those other organs back where they need to be, because everything's probably displaced, and then slowly by gravity getting some of that stuff to go in naturally. And then eventually, hopefully within a few days, the surgeons will put the rest in and then seal off the stomach. Kids that are having surgery for omphalocele and gastroschisis, especially when a huge amount of those bowel contents are outside of their body when they're born, they are going to be uncomfortable. So they're going to need some sort of pain support before and after surgery. So these kids are going to be uncomfortable, so some sort of pain support is wonderful. The surgeons will also come in and periodically check the abdominal site and remove dressings. Lately, they haven't been sealing off the abdomen completely for a while to allow for continued adjustments, and in case the bowels don't continue, they find that, some of the bowel isn't working and things like that. So then they don't have to completely reopen everything. When they do come in and do their post-surgical checks, I always try to, and I really ensure that I'm getting those pain meds on board before the doctors start messing around and pushing on that abdomen. So these kids are going to pre-surgery have gastric decompression, so they're going to have an NG tube hooked up to suction, and then slowly, and then after surgery they'll have the same thing, and as we start seeing those abdominal contents clear up, we will slowly start feedings. And when I say slowly, we're only going to do a small amount of feeds every few hours, and it could be as little as like 5 cc's, and to see how the child is digesting that. It may start out once every 12 hours or once every 8 hours, and then as that baby tolerates it, we'll increase it slowly. So it may take a good month and a half or longer before this child is up to what we would consider full feeds to maintain their nutrition. So they're going to be on that long-term IV nutrition before and after surgery. So it is a long process for the family and the baby, and relatively little complications besides any comorbidities they may have been born with. Now, if part of that bowel is necrosed, before they put it all the way back in, they will cut out a section of the bowel and reconnect everything. Okay. So since we've been talking about a bunch of GI issues, we know sometimes with GI issues we have to cut out a section of the bowel. This is called short bowel syndrome or dumping syndrome. And once again, depending on what portion of that bowel that we have to cut out will depend on the severity of the symptoms. So my gastroschisis babies, my TE, transesophageal fistula, and esophageal atresia babies. I'm trying to think any kind of issues where we have to cut out a portion of the bowel. they could have these issues. So some things that we might do is antibiotics to help with bacterial overgrowth, vitamin and mineral replacement, antidiarrheal agents. They may need extended parental nutrition through an IV, and then that slow feeding. What I've noticed in taking care of people that have short bowel syndrome, if they eat a large amount of food at one time, that increases the likelihood of them having that dumping syndrome or that diarrhea and that abdominal pain. So smaller, frequent meals may be more appropriate for these patients as well. Okay, so celiac disease. I know we've all heard of this, becoming more and more common. I just found out this weekend my little niece has also just been diagnosed with celiac disease, so very common. It is an immunologic disorder in which gluten causes damage to the villi in the small intestine. And remember, those villi help with digestion. So the only treatment for a patient with celiac disease is that strict gluten-free diet. Okay? These patients should not eat any gluten because they're just going to continue to have problems, and the gluten is going to kill those not kill those villi, but paralyze them so they don't work. As soon as they stop introducing gluten to their system, those villi start to work again and allow for that nutrition to be absorbed. These kids have satiria, those very fatty stools. They're malnourished. They have abdominal distension, and they have vitamin deficiencies. I believe I have a teaching guide on one of these slides, but if not, it's teaching guide 20.3 on 739 of your book. I would like you guys to look at that. Think about some foods that have gluten in it and some things that don't, and that look at that graph. There's a lot of things that I wouldn't have thought of that have gluten in it. You have to be very careful on manufacturing companies. They have to manufacture gluten-free products in completely different manufacturing areas. Or if they only have one plant, they have to completely sterilize their equipment in between gluten and gluten-free products. So with celiac disease, these kids have a malabsorptions of the small intestines, that permanent intolerance to gluten. Some kids will start seeing the effects of this within 6 months to 2 years of age. The only true diagnosis is that intestinal biopsy, but they can do some blood tests to see if they want to put that patient through the biopsy. They have an inappropriate immune response to ingested gluten and gluten-related products found in, or proteins found in wheat, rye, barley, and oats. This is inherited, so a lot of the times there's another parent that has the disease. As soon as they start clearing the gluten out of their system, they immediately start seeing relief. It may take a few months of reintroducing gluten before they start having major problems again. Some people, it's almost immediate that they have problems. Because of the malnutrition with these patients, you can see that there's a lot of other issues that could be occurring. GERD, the malnutrition, short stature. It's not unusual for them to have other autoimmune issues, anemia, constipation, arthritis, epilepsy, headaches, diabetes, Graves' disease, IBS, Down syndrome, Turner syndrome, things like that. Okay. So what can we do for these families is really help them figure out what kind of diets and what kind of foods are appropriate and things to avoid. Several people I've talked to have found that if they buy their groceries in bulk off of like Amazon, it tends to be cheaper in the long run. But Hy-Vee has tons of really good stuff. They have that whole health market that is for all these specialized diets. And Walmart has some things as well. So families are going to be able to find things, but unfortunately it is more expensive. Okay. Well, if these patients continue to be untreated, they can go into a celiac crisis, which is can have dehydration that leads to that hypotensive shock and lethargy. Okay, they're going to have impaired growth, chronic diarrhea, explosive watery diarrhea when they're in a crisis, and severe dehydration. Okay, if you think about it, if they go into hypotensive shock and lethargy, that could lead to death as well. Corn and rice substitutes are great. There's all sorts of internet resources and chat rooms for patients and parents, but remember, we have to be careful when we're using those internet sites because they're not all accurate. All right, Hirschsprung's disease. This is a common cause of neonatal intestinal obstruction, and it is a form of constipation in newborns because they don't have ganglionic cells in the bowel, which leads to inadequate motility of the intestines. You can have mechanical obstruction and a lack of adequate motility in parts of the intestine. It's not uncommon for kids with Down syndrome to have this, but I've also seen some very healthy children have it as well. It can result in enterocolitis, or that inflamed bowel, which can lead to death. These patients will have fever, abdominal distension, diarrhea, and that can lead to dehydration and sepsis. It's not always diagnosed until the first few months of life because one of the diagnosing tools is looking at those first MEC stools and how they look. And sometimes, as we know, babies don't always have that first stool until after that child is 24 to 48 hours old, and they may already be home. All right. So here's a picture of our bowels. Let's see if I can make my marker smaller. Let's go that color. Here we go. Okay, so your ganglion is usually down in this portion, right around where your rectum is, and right below the sigmoid colon. The ganglion cells, and they can also go up into the colon. This is typically right in that area where they're lacking, right in through here. Okay. If those ganglionic cells are lacking, that doesn't allow for that motility and for that stool to continue going down through the rectum, the abdomen, and through the colon and down through the rectum. So what ends up happening is they stop right here, and where's that stool going to go? Well, it's going to keep coming. It's going to keep coming, right? And then it's going to pool all through here, and then we're going to have this huge distended colon. And that's where we're going to see the abdominal pressure. Some stool will come out, but remember, when somebody has that impaction, what comes out? It tends to be more watery. Well, that's what sometimes happens with that first MEC stool. It becomes watery, and that parent who's never had a child before is like, oh, they're stooling, it's good. But it may not be, right? Because we know that MEC stool is very sticky. And, okay, so right there's the ganglion. That MEC stool is very sticky, and it's very dark, and it shouldn't be wet, loose, okay? And then we have this backup. So what do we do to diagnose? We do an x-ray, barium enema to look for that narrowing. We can do an anorectal manometric exam. So the doctor's going to put his finger right up into the rectum, and they're going to expel some of the stool. True diagnosis is doing a biopsy. So they stick this air-guided, air suction gun up into the rectum, and when I'm doing that, helping that baby, I'm going to be calming the baby, making it comfortable while that doctor is doing that biopsy. And they want to make sure that they put pressure on the side of the rectum with that gun, so that when they use the air enema or the air syringe and push on it, this little knives can pop out, take a good sample of biopsy, and then they get a good tissue sample, because they're going to look for those ganglionic cells. If they don't see any, therefore they know there's a ganglionic, or they're missing, and that's what's causing issue, and therefore it's Hirschsprung's disease. Okay, so these are the signs and symptoms. The kid's going to initially eat. They're going to fail to pass the meconium school. They're going to have intolerance. They're going to start distending. They're going to have constipation. Like I said, they're going to have loose, ribbony like stools, and they are kind of foul smelling. And then you're going to be able to feel mass. So what do we do for these babies? We got to fix it. So how do we fix it? We're going to do surgery. So I want you guys to think about it. What kind of things do we do for a patient that's going to have abdominal surgery? Well, we're going to make sure we're doing gastric decompression. Then we're going to not be feeding them. Think of all that preoperative care and postoperative care and education. These kids are going to end up with a temporary ostomy. So we're going to pull through part of that intestine, and they're going to stool into an ostomy bag. We're going to allow for healing. We're going to get rid of that portion of the bowel that doesn't have the ganglions. We're going to allow everything to heal. And then we're going to eventually reconnect everything. Okay, this could take months. It could take weeks. Okay. While we're waiting for everything to heal, we've done abdominal surgery. So what are we going to look for? Enterocolitis, fever, abdominal distension, that chronic diarrhea, explosive stools, rectal bleeding, and straining. The same thing's going to happen when we reconnect everything. We can look for signs and symptoms of ileuses, all that good stuff. Some of these kids will go home with an ostomy. Most kids do not, in my experience, because they are usually premature and sick. So if they are going to go home with ostomy, we'll have to do that extra care on teaching the parents the signs and symptoms, how to deal with an ostomy bag, and the signs and symptoms of impeding issues with the abdominal system. Okay. All right, we have intussusception. Intussusception is when you have a telescoping or invagination of one portion of the intestine to the other, like you can see in the picture. This can be due to intestinal lesions. At the site of the appendix, if there's polyps. Some people have said when kids have gotten the vaccination, the one that's liquid, and I'm blanking on it right now. But anyways, infections, things like that. Okay. So as we know, this does not look comfortable. The kids that are typically affected by this are males. Like I said, there's some sites of it where there's a diverticulum, the cysts, polyps, tumors, cystic fibrosis, kids with celiac disease, Crohn's disease, because there's inflammation and problems going on with the abdominal system. Rotavirus, that's what I was thinking, the rotavirus. Kids that have had rotavirus sometimes have issues as well. Okay. So, most common in kids between the ages, under the age of 5. So, peak incidence is that age of 3 to 9 months. More common in boys and children with cystic fibrosis. Like I said, we don't usually know. These kids end up having intermittently colicky abdominal pain, vomiting, bloody stools with mucus, and it's this current jelly-looking stool. And the only way to confirm it is by doing ultrasound. One little girl I know, she's not little anymore, she's in like junior high. She had 3 bouts of intussusception before they finally diagnosed it. And she was right around, I want to say, that 9-month mark. She had this horrible abdominal pain. They took her into the ER. By the time they ran all their tests and got everything done, and they did a ultrasound, she felt better. Second time they brought her in, same kind of things. They got to the ultrasound a little bit faster, but once again, it resolved itself. The third time, they had the same doctor that they had the last time, and he went straight for the ultrasound. And sure enough, they caught the intestine being telescoped into the other one and it's just slowly releasing itself. And they were able to confirm that it was the intussusception. Hers, if I recall correctly, they just had to do an air enema to pop it out, which I will talk about that here in a little bit. Alright, so here is an example of an ultrasound, and as you can see, kind of right in this area, the intestine is inside of each other. And here's kind of the current jelly looking stools. Let's do that. So right here you can kind of see some blood maybe. You can kind of see right in here, if you've ever seen like a jelly, it's got that jelliness to it that's not normal. Then you can kind of see that there's some seeds. Kind of looks mucusy in a way. Okay. So most kids, 10% of the kids there will spontaneously reduce. And then we have to go back in and do a radiologically guided air enema or an ultrasound guided hydrostatic saline enema to reduce the defect. It does reoccur in 1 in 10 patients. Like I said, that little girl I knew had it like 3 times. If it does not go back by doing an enema, they will go in and surgically reduce the telescoping. Now, if you think about it, if that intestine has been telescoped in there for a long time, you have blood flow issues, you have swelling, you have irritation. And what can that cause? Necrosis. So when they go in to surgically reduce, if they have any area that's necrotic, they will cut that out. And once again, that could put that patient at high risk for dumping syndrome. Pre-procedure, we're going to start an IV, get the fluids going, and decompression, antibiotics. Okay, hopefully, just doing those air-guided enema, that'll work. And then we won't have to go in and surgically reduce it. Okay, esophageal atresia and tracheoesophageal fistula. Okay. This is a lack of normal separation of the esophagus and the trachea during embryonic development. Esophageal atresia is a congenitally interrupted esophagus, so it ends in a blind pouch. The tracheoesophageal fistula, you have abnormal communication between the trachea and the esophagus. These kids tend to have hydramnios. They all have copious frothy bubbles of mucus and drooling, and they can all have abdominal distension. Both of them are going to have the 3 C's: coughing, choking, and cyanosis. Esophageal atresia and tracheoesophageal fistula. This occurs during that 4th week of gestation, so even before that mom knows she is pregnant. And they can occur together or separately. And how do we diagnose it? Is that X-ray. Most of these infants have smaller than average birth weight, and typically they are considered born early or preterm. A lot of these kids have polyhydramnios. They can also have cardiac and renal anomalies. So both esophageal atresia and tracheoesophageal fistula will have lots of salivation, drooling, coughing, choking, and cyanosis. They can be apneic. They can have an increased respiratory distress during and after feedings because what's it going to do? It's going to back up and could go back into the lungs, or if there's a fistula, it can go right through that hole through the lungs. This kid's going to swallow normally, and then we have that high risk for aspiration, and milk is going to come out of the nose and the mouth. Treatment is surgery. We can use part of the colon or gastric tube to also bridge if there's missing segments, and I will talk about that more here in a little bit. We will need, I don't know. We may need esophageal dilations as infants and children on managed strictures. Okay, nursing management. This kid's going to get surgery. They're going to be NPO. Their head's going to be elevated. They're going to need hydration and fluids, oxygen and suctioning equipment available, comfort measures, education because of the surgery. Post-op, they're going to be a while before they're able to start feeding, up to a week, and lots of education. I will get into more of that later. Okay, here's an example of what we see. So we have the trachea, the lungs, esophagus, and the stomach that all work together. Then we have the atresia right here, where you have that blind pouch where the esophagus is not connected.
What's esophagus?
Okay, so you have the esophagus that's not connected, so you have that atresia, so you have this blind pouch. Then you have the fistula on this one, where you have an opening between the esophagus and the trachea. So you have that area where that food and things can go down into the lungs, but the esophagus is connected down to the stomach. However, you can have an atresia and a fistula. So you can see that you have the fistula here, and then you have the blind pouch. So you have nowhere for food to go down in here, and you have an opening here that makes it even easier. Now with the atresia on this one, the food can go up here and go back down, and then up and out through here. This is normal. That's not. All right, so here's another picture of just some of the esophageal atresia in an X-ray. So you can see that we have an atresia, and there's nowhere to go. There's no air in the abdominal sac, so there's no connection from the esophagus down. And when they put the NG tube down, it just curled up and went right back out. There's different types depending on the severity. These kids will have some vertebral, anal issues, cardiac issues, renal issues, things like that. They also will have those 3 C's. You can see it by ultrasound, and typically we'll see in ultrasound that there's no air in the bowels, which we should see even on ultrasound in those babies. This mom is going to have polyhydramnios, and the baby's just going to have some struggles. Okay, tracheoesophageal fistula. We have a connection down here because we have air in the belly, but we see the NG tube curling back up. What it's doing is going from the esophagus in through the trachea and back up again. So you have that incomplete separation of the esophagus and trachea. They're going to have the 3 C's as well. Can have polyhydramnios. This one is not often diagnosed in utero because that abdomen is filled with air. Okay. So, I want you guys to look at this YouTube link. We're going to look at it in class. This is actually one of the big surgeons explaining some of these. So what do we do for surgery? We're going to ligate if there's a fistula and connect everything up. So that's what they're kind of doing here. Well, this is actually the atresia that they're connecting together, but you can also see right here with the trachea that some of it was connected. So they're breaking that apart, closing that hole off, and then they'll connect these two. It's going to be staged. A G-tube is going to be placed for decompression and feeds. These kids are going to need to be constantly suctioned until they're born, until everything's repaired, because we don't want them to aspirate into their lungs and get pneumonias. It could take up to a year to completely finish all their surgeries. Okay. Let me make sure I'm not forgetting anything from my notes. All right. So, preferred position for these kids is the head of bed, flat or down to facilitate drainage post-surgery. Okay. Otherwise, their head of the bed is going to be elevated pre-surgery. Okay. We're going to put a Ropogal or ventrolivine and G-tube down for low constant suction to suction everything out of the stomach before and after surgery. We don't irrigate it. These kids are probably going to be ventilated for a while. If we're going to be repairing the esophagus and we're going to have sutures down in there, we do not want to stick anything down past that kid's throat. So I'm not going to do deep suctioning. Before surgery, I'm going to be doing tons of deep suctioning to get all that secretions out. Post-surgery, no deep suctioning. Pre-surgery, you can suction. Post-surgery, we don't want a deep suction. They may have a chest tube. If an NG tube is placed in that baby during surgery, the only thing I can do with it is put the feeds through it. I do not want to pull on it. I don't want to replace it. I don't want to be messing with it other than to hang the feedings. If it comes out, we're paging surgery because I don't want to push it back in and with fear of damaging the surgery. Okay, so some complications. Leaking into air leaking, fluid leaking into the thoracic cavity. Pus as well. Strictures could be redeveloped after 3 weeks post-op, and a sign of strictures would be that brassy stridors, cough, trouble breathing, the 3 C's showing up again. That's some stuff we're going to have to teach the parents about. Poor mobility, a new fistula reoccurring, signs and symptoms of pneumonia or sepsis. Because we're messing with near the diaphragm, we can have paralysis of the diaphragm, tracheomalacia, and reflux. Okay, necrotizing enterocolitis. This is a serious GI issue in newborns, especially your preemies. It is the most common disease in preterm infants and is associated with chronic morbidity and mortality. They have inflammation and invasion of the bacteria in the bowel wall. It affects about 10% of infants that are less than 1,500 grams. It has a 50% mortality rate. However, these statistics I think are pretty old because I hardly have seen a child die from this since in my 10 years. I can guess about a handful. And the mortality rate cost is about $100,000 per case. So some things to look at. This kid's stomach is really distended. It's really tight, and you can kind of see it's shiny. You could almost see some bowel loops right in through this area. If you were to push on this stomach, it's going to be very tight and it's going to hurt. You can see this kid is very lethargic and floppy. You can see the blood vessels through here. You'll probably see some peristaltic waves if he's having any. And then you can kind of notice the ruddy red color of his skin. All right, so their book talks about 5 mechanisms of enterocolitis. I consider them more 3, and the other 2 kind of lead to the bowel ischemia and the flora. The immature intestinal barrier increases your risk for ischemia and bacterial flora. And then perinatal stressors. I think that's feeding these kids too soon, and then also just being premature. All kind of lead together. So you could look at it at either 3 or 5, depending on how you want to break it down. So what happens is, with those stressors, is the O2 is shunted away from the gut to more important organs such as your heart, your lungs, your brain. And so that increases your risk for bowel ischemia as well. And if you're having ischemia, that's going to cause that deadening, and it's not going to allow that baby to digest things as well. Things that are risk factors, prematurity, diabetes during pregnancy, drug use during pregnancy. Trying to think. There's a whole gamut of things. And I'm kind of blanking on some of them. Box 24.1 in the Ricky book is amazing. It kind of breaks these down even better. Polyhydramnios, preeclampsia, multiple gestations, things like that. So what are we going to see? I kind of explained some of these in that other picture, but that abdominal distension and tenderness, they could have bloody stools. Feeding intolerance. So before I feed these kids, I check to see how much of their milk is digested and what it looks like. If it looks bilious, I'm not going to want to feed them, and that could be a sign that their body isn't digesting as well. Signs and symptoms of sepsis, the lethargic, the laying there and being kind of floppy, apneic episodes, and shock. We can do an x-ray, and we're going to see air in the bowel and dilated bowel loops. We're also going to do some blood tests and look for metabolic acidosis, increased or decreased in white blood cells. They could have thrombocytopenia, electrolyte imbalances, and they're going to have elevated CRP levels. All right. This is the box that I was trying to memorize off the top of my head. Preterm labor, sepsis, prolonged rupture of the membrane, RDS, exchange transfusion, low birth weight, low APGARs, asphyxia, so that lack of oxygen, hypoglycemia, bunch of other things related to that. These kids are going to be super sick. They are going to need to be rehydrated after their belly rests. So how do I take care of this kid? I'm going to put excuse me, I'm losing my notes. They're going to be on bowel rest for 10 to 14 days, meaning they won't be fed for 10 to 14 days. They're going to have a ventral lavine or an NG tube that is put to low constant suction. All of their feeds are going to be done by total parental nutrition, like CVN, NVN. They're going to be, we're stopping feeds immediately as soon as I see any signs and symptoms. We're going to start antibiotics. We're going to do infection screenings. I'm going to watch for the blood in the stools. I'm going to measure their abdomen frequently. I'm going to assess that abdomen for the tenderness, the bowel loops, the distension. I'm going to listen for those bowel sounds. Are they active, hypoactive, absent? Is that baby tender, rigid, that shininess? Some supportive care. I need to explain to the parents what we're doing. If the neck is severe enough, these kids could end up with a bowel resection as well, because it can cause necrosis to part of their bowels. I always tell the parents that we stop feeds for any impending doom, as I like to call it, because we want to catch it sooner rather than later. And sometimes we just have these false positives, or I mean false signs of neck, and then we only have to do some of these things for 48 hours. But if it is truly neck, it's going to be 10 to 14 days of antibiotics and no feeding. And then after that, it's going to be slowly restarting the feeds to get them back to where they are. We're not going to be able to start those full feeds right away. If we do have to go in and resect any portion of the bowel, we're going to end up with a temporary ostomy again. Some kids end up with long-term ostomies. We can educate them on the ostomy cares and things like that. Okay, this is just a review slide. It should not be new to you guys. This is just, once again, a reminder of oral rehydration therapy in those older kids. Any kid that's had a GI issue, they have gotten dehydrated, this is what we need to do. Remember, tap water, milk, undiluted fruit juice, soups, and broths are not appropriate for oral rehydration. We need to have that Pedialyte or Risolite, something that has a really good electrolyte balance to it. This is kind of another review, kind of an overview for everything we've kind of talked about today. If we're doing NPO, all oral feeds are being withheld. We're going to do indwelling nasal catheters for gastric decompression. Medication for reflux if we're having lots of issues, and we can do lots of pacifiers for pain management in infant. Some psychological concerns for these parents. Children are considered medically fragile for lengthy periods of time. There's not much anxiety related to bowel resection, or there's a lot of anxiety. Parents are like, I don't want to deal with that. Ostomies have a lot of poor, have a lot of a negative thought out there. They're really easy to live with. People don't realize that because stools and stuff are nasty according to people. So getting over that stigma, that long-term hospitalization, the cost of everything. Some of this stuff can lead to death. So what do we do to help those parents if this child will die from a severe infection? We got to think about all of that stuff. Help the families become experts on their child's needs and their condition. They're going to have to learn how to take care of their child, and be just as good as a nurse with a lot of these long-term issues. All right, infants of diabetic mothers. This should be somewhat of a review again for you. 6 to 10% of moms with diabetes mellitus, they're going to have anomalies for the babies. Shoulder issues, cardiac issues, different things. There can be microsomic, hypoglycemia, RDS or respiratory distress. They can have polycythemia and hyperbilirubinemia. So what are we going to assess for? Low blood sugar, thick viscous blood, tremors, lethargy, breathing issues. So extremely fast to apneic breathing issues. So what causes this issue? That high level of maternal glucose crosses the placenta. That stimulates the increase in fetal insulin production, leading to that huge growth in that fetus. And then when that baby is born, what happens? That kid has huge fetal insulin production, but now it's not getting that sugar. It's not getting that glucose, and that just causes all that glucose to be depleted immediately. And that kid's going to have super hypoglycemic episodes. Okay, the full rosy cheeks, and when you saw in that little picture, ruddy skin color, the redness, the short neck, a big hump on the back of their neck called the buffalo hump, massive shoulders, a distended abdomen, lots of extra fat, signs of hypoglycemia, and birth trauma because that huge baby getting through that little tiny hole. Huh? We're also going to have the possibility of low calcium low magnesium, that increased hematocrit levels, and hyperbilirubinemia. So what do? Frequent oral feedings, neutral thermal environment, rest periods. Remember, these babies don't always feed as well either. So we're going to have to really work with them to get them to do that good suck swallow. We're going to possibly have to do IV fluids and electrolyte balances. We're going to have to check their glucose quite frequently. Each hospital has a different protocol, but a lot of the times it's going to be quite frequently the first 24 hours and then with feedings. Explaining the importance of feeding this child, why we're doing supplements, the importance of the mom breastfeeding and pumping to increase that demand and get that milk produced. And why the baby's kind of sleepy because of the high bilirubin levels. Why are we putting them under bilirubites? And explaining all of that to them. Almost done, you guys. I know this is a long one. Classification of diabetes. So you guys should know the difference between type 1 and type 2 already. So I have them defined here. Some diabetes can also be due to cystic fibrosis, glucocorticoid use, genetic syndromes, Klinefelter-Downs, Turner syndromes, and we know of gestational diabetes. Care difference with children from adults due to the physical and developmental differences. And children are very dependent on their caregivers, and if occurs in multiple settings, schools, daycares, after schools, moms versus dads, grandparents, all that. As that kid's developing, insulin sensitivity varies as that child grows and goes through sexual maturation, so that throws off and makes it very difficult. Type 1 is an autoimmune disorder when the B cells are damaged and result in inadequate insulin secretions, which lead to the inability of cells to pick up glucose, which leads to hyperglycemia, glucose accumulation in the blood, and the body's inability to maintain the source of fuel. Kidneys will try to lower the glucose, so they'll have glycosuria, polyuria, and protein fat breakdown, and the metabolism of fat leads to the buildup of ketones and acidosis. With type 2, there's a resistance to insulin. What happens to that patient if they are not adequately treated? They have failure to grow. They have delayed sexual maturation, poor wound healing, recurrent infections, especially at the skin, retinopathy, neuropathy, vascular issues, peripheral vascular disease, cardiovascular disease. All those things that you see in our adults with diabetes. Some other developmental issues that I want you to look at is a graph on page 106 of your Kyle book. We will try to talk about it in class. It's things to look at, what I can do with an infant and what affects there to that teenager. This should be review again. Diabetic ketoacidosis is fat catabolism. Deficiency or an ineffective insulin in which the body is using fat instead of glucose for energy. It is considered a medical emergency and we need to provide quick intervention. Things that can lead to ketoacidosis, stress from illness. Stress from illness, infections, surgery, hormones produced during those times of stress. And those all lead to decreased insulin sensitivity and increase in glucose production. When you're sick, okay. Here's a nice chart breaking down the difference between type 1 and type 2 if you can't remember those. Risk factors. Family history or parent with type 2. Native American, African Americans, Latinos, Asian American, Pacific Islanders are at high risk. This is typically more for the type 2 diabetes. Insulin resistance, so dyslipidemia, hypertension, history of maternal diabetes, kids that are older than 10 years of age and onset of puberty if it occurs before the age of 10. So this tends to be more your older children. However, we're seeing type 2 diabetes more and more common in our younger children due to our diet and inactivity. So what do we got to do for our kids that have diabetes? We need to achieve normal growth and development. So we need to monitor those blood glucose. We need to refer to goals specific for their ages. And looking at the different ways to test for glucose. The smaller they are, maybe we need to do smaller pricks, trying different insulin testing devices. How about different ways of giving insulin, to putting in like a insulin pump. Each kid's going to be different. Typically we do AC and HS, however they may get more frequently or less frequently. We need to teach parents how to record and get that good diet and glucose manuals going. Hemoglobin A1C is also checked on these kids, but it's different than those in the adults. For kids 0 to 6 years of age, we want a 7.5 to 8.5 hemoglobin A1C, so it's slightly higher because of all the changes their body's going through. 6 to 12-year-olds, it's 8. 13 to 19-year-olds, we're going to less than 7.5. So it's getting closer to normal as that kid gets closer to the adulthood. I'm not going to spend tons of time going over the different types of insulin. You guys should be aware of this. I'm not going to spend tons of time lecturing on it. If you don't remember it, please review. Insulin is given sub-Q. U100 can be given by pumps only. Okay, so if you don't know what U100 insulin is, you better look that up. Every child will be different dose and different frequently, just like we saw in the adults. It's not unusual for 2 to 4 injections a day. They do need more injections or more higher doses of injection during those growth spurts and times of illness and stress. Insulin pump, pros and cons. Pros, the constant insulin that's going through, it's going to control the diabetes and the highs and lows of the insulin a little bit better. However, that child must be able to count carbs and monitor glucose levels frequently. We can also do oral meds like we use in the type 2 diabetics, but there's some side effects to those: headaches, dizziness, gas, GI issues, edema, liver enzyme elevation. Insulin injections may be needed if the oral meds are not working. We also need to remember diet and exercise are also important parts of diabetes management. Okay, retinopathy. Eye exams by experts with diabetes once the child is 10 years old and they have been treated for 3 to 5 years for type 1. Type 2, soon after that child is diagnosed, they will get tested for retinopathy. Nephropathy, the annual screening for leaking of small amounts of albumin into the urine once that child hits 10 and has been diagnosed for 5 years for those with type 1 diabetes, or for type 2 diabetes, annual screening soon after diagnosis. Dyslipidemia, we're going to start screening these children over 2 with a family history of high cholesterol and cardiovascular disease. We're going to do lipid panels at time of diagnosis, and then it will be taken at puberty. Celiac and hypothyroidism will be done every 2 years once glucose levels are stabilized. These are very common issues that we see with diabetes. We are going to look for complications such as acidosis, hyperkalemia, hypokalemia, hypocalcemia, cerebral edema, and hyponatremia. If that child is hypoglycemic, what do? We're going to give glucagon when it's severe by sub-Q or IM. We can do dextrose IVs. If that child is coherent, we can offer 10 to 15 grams of a simple carbohydrate, such as OJ, orange juice, then followed up by peanut butter and crackers or something similar. If you don't know your signs and symptoms of hypo versus hyperglycemia, I recommend you review that. When educating the family, what do we need to discuss? Page 1014 has some really good things in the Kyle book. How do you measure glucose? How do you do urine keto testings? The different types of medication and the durations. Those signs and symptoms. Sick care management. So what do we do when that child is sick? We don't stop giving the insulin, right? Explain that to the parents. Tell them the importance of that. Diet and exercise is just as important as following along with a proper diet. Okay. And these are some examples of some nursing diagnoses. I'm sure there's even more that we could do. All right, that's it for this this lecture. If you have any questions, feel free to ask me. Thanks.